Hello and good morning, afternoon, or evening. Welcome to our BEUS cast on EFAST pitfalls. I'm Ruben Hazendonk. I'm the current president of the Belgian Emergency Ultrasound Society, or in short, BEUS. And today I want to discuss the disadvantages of the EFAST protocol. Of course, the extended focused assessment with sonography for trauma is an extremely useful tool in the emergency department. But we need to understand primarily our own limitations and also the general limitations of this point of care ultrasound exam. We use EFAS typically in the setting of trauma care and obtain specific views of the heart, abdomen, pelvis, and lungs to quickly assess patients for signs of internal injuries and guide further medical interventions. We will not go into depth on how to perform the exam, and I also won't go over general ultrasound limitations for time's sake. First of all, know your own limitations. Ultrasound imaging requires skilled operators who are trained in acquiring and interpreting ultrasound images. Inexperienced operators might not be able to obtain accurate images, leading to potential misdiagnosis or missed injuries. The number of EFAST exams necessary to become proficient can vary depending on several factors, including an individual's prior ultrasound experience, their training program, and their ability to consistently interpret and acquire high-quality ultrasound images. When we go through the literature, and specifically the American and the Royal College of Emergency Medicine recommendations, roughly 25 scans are required to obtain a certain level of proficiency. Some recommendations will indicate higher numbers, but most of the recent guidelines don't go up to more than 50 scans. These numbers are adapted by the Belgian Emergency Ultrasound Society. My personal point of view here is that 25 is really the absolute and bare minimum. You would also need to consider that many of us work in settings where most of the exams, luckily, will end up negative, and thus imaging 25 different patients might not be enough. Proficiency in EFAS exams requires a combination of training, practice, and also ongoing skill development. So an extra tip is to review pathological images online. You can find a lot of good material on sites like the POCUS Atlas, Radiopedia, and YouTube tutorials in general. One of my favorites being Western Sono on YouTube. That being said, 25 scans are not an enormous amount, and the learning curve is indeed very steep. As an example, it's way easier to learn EFAST than ECG interpretation, because your clinical question is very clear on just a few specific views. It's not a comprehensive abdominal investigation. Is there pericardial fluid? Do you see signs of peritoneal free fluid? Or evidence for a hemothorax or pneumothorax? Period. That's it. The second point I want to make is a limitation of the images. When acquiring images, never say there is no free fluid. A negative EFAST result does not rule out possible injuries or even free fluid. You can make the best and crispest images of all views needed, but a patient might still have injuries that are not visible with ultrasound, leading to a false sense of security and potential delays in further evaluation or treatment. At least 200 to 300 milliliters of blood in the peritoneum is necessary before you will be able to visualize it with your probe. I repeat, 200 to 300 milliliters. For a hemothorax, this is about 50 to 100 mLs. Also, you're looking for free fluid. Significant hollow visceral or parenchymal injuries without free fluid will be easily missed. On the other hand, small amounts of free fluid are in many cases an argument for watchful waiting in the setting of trauma, as are parenchymal injuries without hemodynamic compromise. Of course, you know you will go to CT for further diagnostic workup in these hemodynamically stable patients. For the visualization of the lungs, we know that the presence of lung sliding is an excellent rule-out for pneumothorax, but only at the spot where you are holding the probe, so scan enough zones. Many things can result in the absence of lung sliding. For example, main stem intubation. But In this case, check carefully for the lung pulse, which you can see here. This is the movement of the heart through the lung tissue. Furthermore, chemical pleurodesis, fibrotic lung diseases, a severe consolidation, and ARDS can severely impact the sliding of the pleuras. Also, be careful with subcutaneous emphysema. This might give you a false impression of absence of lung sliding. Subcutaneous emphysema obscures the rib shadow and pleural line that lie below it and should not be mistaken for the pleural line. I will share a personal case I encountered in Iraq. A few years ago, I was working there in a hospital when the battle for Mosul was taking place. We saw a lot of war wounded, and one soldier presented with a gunshot wound below the left axilla, dyspnea, diminished breath sounds on the left, and subcutaneous emphysema over the entire left chest and neck. Clearly, a clinical case of a pneumothorax, you will think. Well, we could not demonstrate lung sliding, and were prepping for a chest strain when the result for the thoracic X-ray came back and didn't show pneumothorax. Everyone was baffled. This was a high-velocity bullet with a huge energy dispersion on impact below the axilla, which created a huge amount of subcutaneous emphysema and a lung contusion. So, only supportive care was needed. This was one very, very lucky man. This is a case also that demonstrates the importance of holding your probe in longitudinal or sagittal plane when scanning for lung sliding, and not horizontal or transverse. This way, you are sure you're looking at the intercostal spaces and the pleura behind it. Alright, let's move on. Always perform a complete and dynamic scan through the whole zone. We should never rely on a few static views. Fan through the whole quadrant. As an example, blood is most likely to accumulate at the inferior pole of the kidney and the caudal tip of the liver, and from there spread through the hepatorenal interface. If you go to Google Images, here's an example of the very first non-pathological right upper quadrant view you will encounter. This still image, of course, is absolutely insufficient to check for free fluid. So are these images of the right upper quadrant. Let me show you why you might see very subtle free fluid here, but again, as mentioned, check the caudal tip of the liver and the inferior pole of the kidney. This is the same image and this is absolutely not subtle free fluid. This is a big amount. On the left side, or the left upper quadrant, free fluid is most likely to collect subdiaphragmatic or suprasplenic because of the ligaments holding the spleen and kidney in place, which makes the splenorenal interface tighter. Here you can see free fluid on the far field of your screen. And here in this second example, a still image of the left upper quadrant, you won't see fluid in the splenorenal interface, but clearly there is subdiaphragmatic. So again, the importance of complete and dynamic scanning of the different zones cannot be stressed enough, or you might miss pockets of free fluid. Another example that can lead to false negative exams can be encountered in the case of adhesions post-surgery. Always be wary of interpreting an EFAST exam in a patient with multiple abdominal scars because blood can accumulate in atypical spaces. Also, be careful with posterior acoustic enhancement behind the bladder. The reason here is that all these ultrasound waves emitted from the probe are unhindered going through fluid and get reflected at the posterior wall of the bladder, resulting in a zone brightly lighting up your screen with loss of image quality posterior to the bladder. So, decrease the far field gain to be able to visualize fluid behind the bladder, as you can see in this positive clip. So, these were some examples that can lead to false negatives. How about false positives? The most encountered free fluid in the abdomen mistaken for blood is ascites. You will not be able to distinguish these two entities sonographically. So it is possible to have an unstable trauma patient which, on the basis of the positively interpreted EFAST, will be transferred to the operating theater for a laparotomy. I personally have never encountered this in my clinical practice, and it seems like a very rare situation. Another example is a patient with peritoneal dialysis or a VP shunt. Hopefully, you have previous medical information from your patient if this would ever occur. Major trauma with free fluid from rupture of the bladder or big amounts of intestinal contents can also be mistaken for blood, and thus classified as false positive. But these will also require operative intervention anyway. An additional false positive image can result from perirenal fat, or even pericardial fat. Fat is more echogenic than free fluid, but be careful with older blood that will start to clot, and thus will appear similar to fat. What can help you to distinguish the perirenal fat is that it is attached to the outer capsule of the kidney and will move with respiration. As an extra difference, the double line sign can help you. Let me demonstrate this to you. Normally, the border of the liver is not echogenic, as you can appreciate here in this image as an example of free fluid. Whereas here you see a hyperechoic line at the border of the kidney as well as the liver. This is a double line sign. And here you can see free fluid as well as a good amount of perirenal fat. One more point on time constraints. While EFAST ultrasound is designed to provide a rapid assessment, performing the procedure still takes a few minutes, especially if obesity makes your scanning harder or you need to work around immobilization material. In general, and this of course comes back to the first point, a novice performer will take a longer time, which can delay timely interventions. And this brings me to the last point, standardization. Of course, we are talking about EFAST, but suppose imaging is being performed by someone who is confident in doing a fast scan, they might overlook the necessity of scanning the lungs thoroughly. So, at that point, if the performer yells fast negative, you might assume there is no sign of pneumothorax or a hemothorax. Be careful with this false sense of security. To review, know your own limitations. And it takes more than 200 to 300 milliliters of blood loss in the peritoneal space in order to visualize free fluid. Perform slow and dynamic scans. And always check the caudal tip of the liver and suprasplenic, not only the hepatorenal and splenorenal interface. Careful with interpretation after complex abdominal surgery. Lung sliding is a rule out for pneumothorax, not the other way around. Absence of lung sliding can have many reasons, and be careful with subcutaneous emphysema, which can mimic absence of lung sliding. Ascites is free fluid. You cannot distinguish it from blood. And if you suspect clotted blood, look for the double line sign. As a last tip, review pathological images online. You can find a lot of good material. Thank you for watching this BEUS cast on EFAST pitfalls and see you in the next episode.